Welcome everyone to Making the Switch, Benefits Compliance Differences between Fully Insured and Self-Insured Plans. Thank you all so much for joining us. Our moderator for today's call is Patrick Myers. He will be answering the questions you send through the Q&A today. We will try our best to answer all of your questions, but if for whatever reason we are unable to get to your question today, please follow up with your advisor for further assistance. Today's presentation is being recorded. We will be sharing the recordings in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you will receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At this time, I'd like to introduce our speakers for today's webinar. Joining us today are Elizabeth Allen, Vice President and Counsel of Benefits Compliance at NFP, and Carol Wood, Vice President and Counsel of Benefits Compliance at NFP. We're very excited to have them speaking with us today. It is my pleasure to hand over the call to our speaker. Beth, the floor is yours.
Thank you so much, Amber, and good afternoon, everyone who is joining us from across the country today. We're glad to have you to have this discussion about making the switch, benefits compliance differences between fully insured and self-insured plans. As Amber mentioned, your speakers today are Carol Wood and myself. And to jump right in, you know that we always give you the disclaimer that generally this presentation is for informational guidance, and we are neither your lawyer or your accountant. And so we're just providing kind of just, again, informational guidance for you today. So I wanted to start off today. The name of the presentation is Making the Switch. And I want to know, out of all of you who are participating today, how many of you already made that switch from fully insured to self-insured? And if you haven't, where are you on that kind of continuum or spectrum? And so Amber has kicked off the poll, and if you could answer that, we'll give a few seconds and then we'll see what we're dealing with as far as the people who are participating today. Insert Jeopardy music here. And we'll wait a few more seconds for people to answer. And then Amber, if you could go ahead and show us the results of that poll. Oh, wow, we have a pretty even split. Okay, so we have 33% of you or so who are already self-insured or level funded, 31% of you who are considering becoming self-insured in the near future, so maybe the next renewal year. And then there are plenty of people here who are a ways off from becoming self-insured, so that's interesting because you're definitely just here to learn today, so welcome. And so with that said, we kind of have a full agenda today. We're going to be going through kind of each of the benefits related laws that kind of have key implications for the differences between fully insured and self-insured plans. We didn't go into this kind of from the standpoint of every single benefits, obligation that might change slightly. We really wanted to focus on the big kind of picture items where there are clear differences. I'll also point out that, the idea of being self-insured versus being self-funded are technically the same thing. We went through and tried our best to only use the term self-insured, but keep in mind that if self-funded made it onto any of those slides, it's the same concept. I think the industry leans more towards self-insured because that's a little bit easier to understand when you realize that there's also a concept concerning being a funded plan, which Carol will discuss in a little bit. But keep in mind that if you see self-insured or self-funded, that's the same thing. And then as far as the agenda, we're going to go with the self-insured plan overview, talk about coverage mandates, ERISA, COBRA, HIPAA, ACA, and non-discrimination rules. And then we'll end out with some final takeaways. So to start off, Carol, do you want to go ahead and give us the self-insured plan overview?
Sure, I'd be happy to. Thank you, Beth, and good afternoon, everybody. Happy to be with you today. So we'll start out, as Beth said, with an overview and some of the terminology that we'll be using. With fully insured plans, the employer is contracting with and paying a premium to the insurer to assume the financial obligations for all plan claims and administrative costs. By contrast, with a self-funded plan, the employer assumes responsibility for all financial risks of plan claims and costs, and stop-loss coverage can reduce some of this risk. A level funded plan is a bit of a hybrid solution where the employer pays a set monthly amount to the insurer to cover estimated claims, the stop-loss premium, and plan administrative costs. And of course, are lower than expected, the employer may receive a refund. And just to stop here, for benefits compliance purposes, the level funded plan is really considered a self-funded plan, so the same obligations would generally attach. What is stop-loss insurance? Stop-loss coverage provides protection against unexpected high or catastrophic claims that exceed a certain level over a specified period, which is usually a year. Now, there are two basic types. Individual, that protects against large claims incurred by individuals by creating a payment threshold or a specific deductible. So if a single claim exceeds the threshold, the stop-loss carrier will pay the post-deductible amount. Aggregate applies when the plan's total claims exceed a predetermined benchmark. At that point, the stop-loss insurance will then kick in and reimburse the plan for claims paid in excess of the threshold. What are the potential advantages of self-insurance? The coverage can be customized to the employer's goals and employee population. There's a lot of flexibility. The plan is not subject to state insurance laws and mandates that we'll be discussing momentarily. The employer has more control over selecting, monitoring, and coordinating plan service providers. The employer may be able to retain funds if the health claims are lower than anticipated. There are also potential cost savings because, unlike insured coverage, there are no profit or risk margins paid to the insurer or state premium taxes. And the possible disadvantages, well, the employer is exposed to financial risk of loss. This could be due to employee demographics, an older workforce, and unexpectedly high claims. Plan costs and expenses may be unpredictable. There also could be a risk of in-house fraud due to the employer's greater financial involvement. But mainly, our focus today is that the employer has increased fiduciary and compliance obligations, and understanding these obligations is key. Otherwise, the employer could face penalties and even lawsuits due to errors in oversights. Moving on to coverage mandates. Are self-insured health plans subject to state insurance coverage requirements? And the answer here is no. State insurance coverage mandates apply to ERISA fully insured health plans, but do not apply to ERISA self-insured plans. So a fully insured plan situs in New York must comply with the state's fertility benefit mandates, but a self-insured plan is not subject to these requirements. There are many state laws. Connecticut may require vision and dental coverage for adult children to a certain age. Florida introduced new coverage for newborn children hearing. So there's a lot of state requirements, and the self-insured plans would not be subject to these. Well, why are self-insured and fully insured plans treated differently? This is all the concept of preemption, that federal law supersedes state law. So the general rule here is that ERISA preempts on state laws that quote unquote relate to ERISA plans. That means the state laws cannot be enforced against the self-insured plan. The goal behind this was uniform benefit administration, so employers operating nationwide didn't have to comply with various state laws. However, there's a big exception here, and that's that ERISA does not preempt state laws regulating insurers and insurance policies. ERISA calls that term the savings clause, meaning state insurance laws are saved from ERISA preemption. So as a result, fully insured plans are subject to both ERISA and state insurance laws. But self-insured plans are not deemed to be insurance or insurance policies for this purpose. That's the term redeemer clause, and thus they're not subject to state insurance mandates. And that's the legal reason we end up with that dichotomy.
Hey, Carol, you're just a little bit muffled. If you could get a little closer to the laptop mic, that would be great.
Okay. Can you hear me now?
That is better.
Okay. So what coverage restrictions and parameters apply to a self-insured plan? Generally, sponsors of self-insured health plans have wide discretion in terms of plan design including possible benefit coverage limitations and exclusions. First, to receive tax favored treatment, expenses must qualify as Section 213D medical expenses. However, a self-insured plan should select a state benchmark plan, which would identify certain covered benefits as essential health benefits. And a self-insured plan is not mandated to cover these essential health benefits like small group and individual plans. But if the essential health benefits are offered, the plan must follow the chosen state benchmark and could not impose annual or lifetime dollar limits on those essential health benefits. So as an example, let's just say an employer is willing to cover bariatric surgery, but they do want to place an annual limit on it. Then they would want to select a plan, a benchmark plan that would have bariatric surgery listed as an essential health benefit because they wouldn't be able to impose those annual limits. And the good news is that the self-insured plan sponsor can select any state benchmark plan. The sponsor in New York would choose the Utah benchmark plan if they wish to do so. And the CMS website provides information on the various state benchmark plans, and the website link is provided here. And Beth, I know we're often asked the question, where, since you're our plan document resource here, where is that normally, the selection of the benchmark, where is that normally noted?
Thanks for that question. So the benchmark doesn't necessarily get, let's say, outlined or listed in, let's say, an SPD or a summary plan description or the plan document. But what we will see generally is that the underlying either insurance coverage or carrier for, let's say, the fully insured plan, or the underlying TPA or ASO agreement for the self-insured plan will provide the benefits as they should be provided under the state benchmark plan that has been selected. And so it's not necessarily a matter of like opening a document that says, hey, your plan chose the New York State benchmark plan, as long as the way that the covered services are listed basically is listed out to reflect that New York was the state that was chosen. Good question.
Thank you. What other coverage restrictions and parameters apply to a self-insured plan? Well, the federal benefit mandates still apply to self-insured plans as they do to fully insured plans. But it's also important to note that a greater obligation for compliance falls on the self-insured plan sponsor. With an insured plan, often these mandates also attach to the carrier, and a lot of the fulfillment of the obligations is taken care of by the carrier. And that's not really the case with your self-insured plans. The sponsor can delegate to service providers certain obligations, but maintains a duty to monitor the service providers and also remains liable. And I think a good example, a current one, is under our transparency rules, those are federal requirements, the transparency and coverage rules that apply to both self-insured and insured plans. And we're now, the machine readable file requirement, if the deadline is approaching soon, and a self-insured employer can contract with a service provider to assist with that, but making sure it's accurate is the responsibility and the liability of the self-insured plan sponsor. By contrast, the insured plan can contract with the carrier and also can contract away the liability for compliance. So it's an important distinction, and it's we take a quick look through the list of federal mandates. The obligation and the challenges of satisfying the compliance requirement can really vary. I think preventive health services, that's one. Certain care, screening, immunizations must be provided in their network without cost sharing. That may not be particularly challenging, but the next one, mental health parity requirements, can be. We know that plans that offer mental health and substance use disorder benefits must offer these in parity with medical and surgical benefits. And by in parity, we mean both quantitative requirements, maybe medical office visits, as well as non-quantitative, which could be experimental treatment exclusions, reauthorization requirements. And the Consolidated Appropriations Act has required a new analysis, a comparative analysis, where the plan needs to compare to really prove that the mental health and substance use disorder benefits are in parity with the medical and surgical benefits for each non-quantitative treatment limitation. And as many of you know, this has been a particular challenge for plans in general, but particularly for self-insured plans. The carriers are providing analysis for most of the insured plan clients now. Whether that completely satisfies the regulators' opinion of what should be analysis is another story, but they are at least providing some type of analysis. But for self-insured plans, the TPAs aren't necessarily doing that. So here's a good example of where you switch to self-insuring, and there are many benefits, but you do have to realize that the compliance obligations, and in this case, some employers may need to contract with their vendor to provide it. And I think contracting is a very important, particularly with self-insured plans, and making sure that your contracts with these service providers indicate that they'll, assist you with complying with not only the current but ongoing obligations. Some of the other requirements under federal law are pretty standard. Minimal hospital stay requirements for newborns and mothers, patient protections, choice of a healthcare provider. There are some new ones under the Consolidated Appropriations Act, the No Surprises Act, surprise billing prohibitions, and also continuity of care requirements, where care must continue at in-network rates if an individual has a serious health condition and the in-network provider has left the network unexpectedly. There's also the COVID-19 coverage mandates. They're still in effect, such as the vaccines and diagnostic testing without cost share. So generally, again, just to summarize, the self-insured plans would not be subject to the state insurance laws. They may have larger obligations to comply with the federal benefit mandates, and they should select a benchmark plan. Now I'm going to switch to ERISA and plan funding. This is an important topic. So how does an ERISA self-insured group health plan fund and pay plan benefits? The plan sponsor must project plan costs and determine the method for funding and paying plan benefits. Although the sponsor has flexibility, the chosen funding method can impact compliance obligations. The basic steps here are as follows. The sponsor is going to project costs. This would require actuarial involvement to assess the projected cost of the promised benefits. Generally, these would be based on past costs and assumptions about future changes. This data allows the sponsor to plan financially, set participant cost sharing, and understand cost exposure. The actual cost may differ, and this is where stop loss coverage protects against unlimited cost exposure risk. Next, I will be determining the funding method, and there are three main methods. Benefits can generally be paid from the employer's general assets. We consider that a quote-unquote unfunded plan, funded from separate funds maintained exclusively for the purpose of the plan, such as in a trust, and or contributions from plan participants or beneficiaries. And then the employer would need to set the payment mechanism, like how are the actual benefits going to be paid, whether directly by the employer from a general checking account or the trustee of a trust. And that should be consistent with the chosen funding method and applicable laws. And that last point may seem obvious and unnecessary, but it's actually often where employers get tripped off. Because, for example, they'll say they're an unfunded plan, and then they'll have an account that's established in the plan name rather than the employer's name. So you just want to make sure you look at all those details and you're not, becoming a funded plan with trust requirements if that's not really your intention. What ERISA rules and requirements apply to plan funding? Under ERISA, certain fiduciary obligations apply to plan assets, which include participant contributions paid towards plan premiums. It includes pre-tax deferrals of the cafeteria plan and after-tax COBRA premiums, certain amounts attributable to plan assets. Insured plan sponsors are familiar with MLR rebates, and also funds held in a separate account for trust for the purpose of paying plan benefits. Any amount in a trust considered plan assets. So the general rule is that plan assets must be held in trust. That's ERISA's rule. And that's pretty standard in the retirement context. But in the health and welfare context, in the case of the cafeteria plan, the DOL doesn't enforce this rule for participant contributions paid toward plan premiums if these amounts are either timely forwarded to a carrier for an insured plan or used to pay plan benefits for a self-insured plan and are paid from the employer's general assets and not maintained in a separate plan account. So a plan sponsor transitioning to a self-insured plan will need to determine if the plan benefits will be paid from the employer's general assets as an unfunded plan or segregated in a separate account or trust, considered a funded plan. In some cases, a trust may be required, perhaps pursuant to a collective bargaining agreement, or if the non-enforcement policy does not apply, maybe there's no cafeteria plan, it's a retiree plan, and it's just post-tax contributions, or perhaps chosen for accounting, tax, or legal reasons. In some cases, the employer may need to take a deduction, for the benefits earlier than they normally would. For legal reasons, keep in mind that an employer is paying from their general assets. Those assets are subject to creditor claims. So there may be legally for the employer want to protect those funds as well. In any case, counsel, tax advisors should be consulted for guidance with that decision. If the employer does decide that they want to establish a trust, then what ERISA requirements apply to plans that fund through a trust? First, you'd have to appoint a trustee. They should be named in the plan document or trust agreement. And the trustee has the authority and the discretion to manage the plan assets. Those fiduciary obligations attach. Trustees and other plan fiduciaries are subject to obligations, ERISA fiduciary obligations, including the duty of prudence, and also the exclusive benefit rule, which requires the trust assets to be used solely to provide benefits for participants and beneficiaries, and also to defray reasonable plan expenses. There's a fidelity bond requirement. So persons handling the plan assets will be subject to bonding. The bond requirement is designed to protect the plan assets against loss due to fraud or dishonesty by plan officials. Just point out this is different than fiduciary liability insurance, which is optional and designed to protect the sponsor against fiduciary breaches. The sponsor may very well be interested in having that liability protection, but having it doesn't relieve them of the fidelity bond requirement. Form 5500 filing. Plans funded with a trust must file regardless of plan size. There's no longer that small plan exemption. And then there's an accountant's opinion required with the annual Form 5500. And this is designed to protect plan assets against loss by requiring plan sponsors to have the plan's finances reviewed against generally accepted accounting principles. And all other ERISA requirements, of course, will apply. The plan document, SPD, claims procedures. And in fact, Beth is going to review those requirements and how they're impacted by a transition to self-funding.
Thank you, Carol. That was a good introduction to kind of just ERISA and the plan funding kind of aspect of self-funded plans. I will say most self-funded plans are not going to be getting into kind of that funded status, specifically because you're going to pay for the claims out of your general assets as the employer. And so then funding is not as much of an issue. But it is important to know if you have any other type of arrangement where, let's say, the money is paid or claims are paid outside of an account that is other than the employer's general assets. So now we're going to move on to just some other ERISA considerations, and then I'm going to start talking about things like COBRA and HIPAA and other implications for self-funded plans. And so ERISA kind of, we get a few requirements that you all are familiar with, and a lot of these requirements are going to apply to both fully insured and self-insured plans alike, with just slight differences in how they would apply, okay? So when it comes to ERISA plan documents, we're talking about the plan document itself, the summary plan description, potential summaries of material modification. And generally, those are going to be required for all ERISA plans, right? So self-funded, fully insured, large, small, we expect for there to be plan documents, okay? But the differences are going to be kind of there between the documents that we find for like a fully insured plan versus a self-insured plan, okay? Generally, all of these documents are going to set forth the plan's rules. They're going to tell employees who's eligible, who's not eligible. They're going to list out the covered benefits, talk about how the plan is administered, as well as how any plan assets are handled. And the bulk of the documents is going to deal with that. I think where we see the biggest difference, if you will, between, let's say, the ERISA plan document for a self-funded plan and one for a fully insured plan is kind of the information that's going to be included along with it, right? So in the industry, what we have created to help with the plan document and SPD requirements under ERISA is this idea of a wrap document, if you will. And that's for two reasons. The first reason is that it can take multiple benefits that might be subject to ERISA, such as medical, dental, vision, short-term disability, long-term disability, and wrap them together to where they are one plan for which you are filing one Form 5500, okay? So that's one function of a wrap. The second function of a wrap is the fact that a wrap serves to basically take an underlying insurance policy or carrier certificate and wrap it with the required content that ERISA is going to want to see out of, let's say, a specific summary plan description, okay? And those aspects of what ERISA requires are generally never in the carrier certificate because those carriers are giving you certificates that kind of are just provided to all clients who have the same product, if you will. And so those are the two functions of a wrap. I think where we see the biggest differences between the self-funded plan and a fully insured plan, for example, is that what the SPD or the wrap document is going to be wrapping is going to be either underlying insurance policies or carrier certificates, or it could potentially be the third-party administrator or administrative services organizations, ASOs, actual kind of contract between that entity and the employer, right? So it looks slightly different. They both still require, provide a lot of information on the benefits that are covered under the plan, but it is a slightly different kind of setup. And I think the most important thing here is just making sure that the terms of the plan are consistent and are followed. One of the issues that you run into with a self-insured plan specifically that we'll talk about just a little bit more later is that if you have terms of the plan that are not administered as they are supposed to be under the plan documents, then normally with the fully insured plan, you just have issues with the fully insured insurer, right? But if you don't do that for a self-insured plan, you could have issues with the stop-loss carrier, in which case you also run into the issue, the circumstance that they could potentially choose not to cover certain claims, which could be a problem. So overwhelmingly, whether self-insured or fully insured, you're going to want to make sure that the plan has those required plan documents and that the plan is actually operated in accordance with those documents. So moving on to the Form 5500 filing. Mind you, again, both fully insured and self-insured health plans that are considered large or have over 100 participants on the first day of the plan year are going to file a Form 5500. That does not change. Carol spent a decent amount of time talking about funded plans and what the results are for that. And if you have a funded plan, then even a small self-insured funded plan would have to file a Form 5500. And so even if you're below 100, if that plan is a funded plan, then you run into that situation of having to file a Form 5500. Where we see the differences, I think, are the schedules that are included with the Form 5500. And so, for example, with a fully insured plan, the insurance policies and what those policies pay out of them to, let's say, certain service providers like brokers and things like that, is going to be listed in the Schedule A, and that's for insured policies only. And so Schedule A's are generally not going to be completed by self-funded plans or self-insured plans. Schedule C, on the other hand, would potentially need to be completed for a self-insured funded plan, and that particular schedule lays out, again, compensation that is paid to certain service providers who are paid over a certain threshold amount, okay? You might also see some kind of hybrid plans, if you will, where let's say elements of the plan are fully insured and elements of the plan are self-insured, in which case you're still going to kind of see those Schedule A's for the fully insured policies, right? So you might have, let's say, a medical that's self-funded, but a dental, vision, life that are fully insured, and you're going to see a Schedule A for those fully insured ones, even if you don't see a Schedule A for the medical, okay? I saw a question real quick, what's the deadline to file the Form 5500? And that's generally by the end of the 7th month following the end of the plan year. But yeah, that requirement doesn't really change based on whether it's self-funded or fully insured. Now, what about claims procedures? And frankly, we could fill up a whole webinar talking about claims procedures. So I'm going to give you a very, very, very high level, kind of review of what the differences are here. I think the main difference to consider when it comes to fully insured plans is that with fully insured plans, the insurer is going to act as kind of the sole claims fiduciary, meaning that they're going to handle all levels of claims adjudication as well as appeals. And then they're going to forward that particular claim if it is pursued further than, the second appeal denial, then they're going to, send that to an independent review organization for an external review, okay? With fully insured plans, generally there is no aspect in which the employer is involved in adjudicating claims, okay? That's different on the self-insured plan side for self-insured plan sponsors who want that to be different, right? We do see a lot of self-insured plan sponsors who actually do, cede the discretion over claims to their TPA or ASO because they don't want to necessarily take part in that, okay? But we also see that some self-insured plan sponsors do choose to actually take part in, let's say, one level of internal appeals, okay? And this is always kind of interesting because first and foremost, the plan documents have to be written to indicate that the employer is going to take on, a level of the appeal. What we will normally see from those self-insured plan sponsors that do that is they might form a committee, right? Because you don't want, let's say, one person deciding on that. But I also think it's important to note that employers who do want to have, let's say, a claims committee that is going to decide on one of the levels of appeal, that they actually are counseled by experts. They are just kind of making the decision based on whether or not, they feel sorry for the employee or just want to cover something that may not be covered under the plan. And the reason that I say that is, just because, a self-insured plan sponsor technically might take over the authority to decide on claims doesn't mean that they are not still bound by the terms of their plan, right? And so if you have situations that can get very difficult, such as determining, let's say, medical necessity and things like that, that generally goes beyond what a normal HR or even C-suite person can do because they're not as familiar with, the situations in which, let's say, some treatment is medically necessary for someone or not. What we sometimes run into is self-insured plan sponsors who just want to take on a level of appeal so that they can kind of sometimes decide to allow for claims that are just not covered under their plan. We generally would hope that you would shy away from that because it sets up terrible precedents. But we would also hope, again, that you're working with experts and professionals that are helping you make that decision. And then obviously, with the self-funded plan, there's still going to be that requirement to provide an external appeal, and that's going to be binding on the plan as well. And so keep in mind that when it comes to claims procedures, self-funded plan sponsors do have some opportunity to potentially participate in a level of the claims procedures, but they'd have to put that in the plan document, and then they still need to make sure that they're complying with the plan's terms as well. All right, so that's kind of just a discussion of some other ERISA obligations. We're going to switch gears and talk about COBRA. And I know we got a number of answers about COBRA and just kind of, or questions about COBRA and what it means for, let's say, non-ERISA plans and things like that. But here we're going to just really focus on the difference between self-funded plans and fully insured plans for COBRA and what that means. I think one of the biggest differences is how you're coming up with the premiums with the fully insured plan or a regular self-insured plan. The premiums cannot exceed over 102% of the cost of coverage, okay? I think the hard part about this, or the different part about this for self-insured plans, is that with a fully insured plan, we know what the premium is because the insurer sets it, right? So if any of us who have a calculator can take that premium and say, hey, 102% of that amount is XYZ amount. And then it's easy to determine what the COBRA premium is, right? For self-funded or self-insured plans, doing that is different. And actually, this is an interesting dynamic because we're talking about it from the standpoint of COBRA, but it's also an issue in even just setting the premium, quote unquote, premium rate period, right? The IRS and DOL gives us two ways to determine what the premium is. The first, and I'll actually talk about these reversed. One way is just taking the past costs and adjusting them for changes in a cost of living index. This is maybe the easier way, but it's also the way that kind of looks, I think, least at a myriad of factors. And so it may not be as robust as the second option, which is to have an actuarial estimate of future costs that takes into account trends, the demographics of the plans, the past costs as well. And those are kind of the two ways that you have that a self-insured plan can calculate the premium. So when we start to look at that from the standpoint of COBRA, that also means that coming up with that COBRA premium is going to involve one of these two methods, okay? Now, that most of you who have a self-funded plan already or who are considering a self-funded plan will work with actuaries who will help you with that, right? So you're not going to be figuring that out, right? You're going to have experts who do that part. And then that's how you will deal with that, okay? Now, determining the premium for an HRA is also somewhat challenging. A lot of employers think that basically you just take the HRA and how much someone has access to, and then divide it by a certain amount of months, and that's how much somebody pays under COBRA. And that's actually not how it works, because the calculation actually has to look at the actual utilization of people who actually take the HRA. And so keep in mind that this is something that you should also be working potentially with your actuaries on in determining what that premium is for the HRA, because it's not as simple as just taking the total amount of HRA funds that someone has available and dividing them by 12 and then charging them 102% of that, okay? And so that's kind of just the concept around the actual premiums involved with COBRA and self-funded plans. How does self-insuring impact additional COBRA obligations? And I think the major point here, I won't go into a lot of what we have here, but I think the major point here is that employers who are looking to, offer, let's say, COBRA, again, under federal law requirements, we know what that says, we know how long that coverage is supposed to be. What we often see with self-insured plans is that they might have more flexibility to offer additional continuation or COBRA-like coverage beyond what COBRA requires, right? So this is a situation where, for example, an employer says, okay, normally you would get 18 months of COBRA, but we like you, so we want you to have 30 months of COBRA. And the important thing there is that a self-funded plan is going to have to coordinate that with the stop-loss carrier to make sure that the stop-loss carrier will agree to that. Because if the stop-loss carrier does not agree to that, then the employer could again be kind of stuck having to take care of those claims, okay? And so just keep in mind that if an employer is considering anything in addition to what COBRA would normally provide under federal law, then you might have a situation where you definitely need to discuss this with the stop-loss carrier. So I think one of the biggest sets of changes, though, that we see is that the HIPAA privacy and security requirements are very different between self-insured plans and fully insured plans, okay? With your run-of-the-mill fully insured plan, the employer or plan sponsor is hands-off as it pertains to protected health information or PHI. So outside of enrollment, they're not getting access to PHI because the covered entity with the fully insured plan is the insurer themselves, and that is who is going to be able to access that PHI and use it to administer the plan. Okay, now, even with that being the case, fully insured plan sponsors do still have some HIPAA obligations under the rules. And you'll see this list here, designating a privacy officer, which most companies need to do anyway for other privacy law reasons. And it can be the same person for HIPAA reasons as well. Running a risk analysis, adopting, not retaliating against employees who exercise their HIPAA rights, doing HIPAA training for employees who might actually have employees come to them and provide them with PHI. These are the kind of things that fully insured plans should also be doing, okay? But then once we switch to self-insured, we see even more obligations on the plan itself to comply with HIPAA, right? And it's important to note that even in the self-funded arena, the plan itself is the covered entity. And so HIPAA really does look at the plan itself as a different entity than the employer. We don't always look at it that way, and sometimes it doesn't work that way, but that is the way that HIPAA is set up. So for example, one of the requirements is to make sure that the employer is only accessing or using PHI in accordance with HIPAA's rules. And I bring that up because of the fact that a self-funded plan sponsor is generally going to have to place a sort of wall between the plan and themselves as the employer, okay? And so if an employer has a reason to receive protected health information from the health plan or through their function of offering the health plan, then HIPAA's rules are going to apply, and there are going to be certain, triggers to what can be done with that information and what cannot, right? So only staff members that really have a need to know should be able to access that PHI, right? We shouldn't have PHI of employees that's just like talked about in some random, staff or upper management meeting, because only the people who really need it for their jobs really should be able to access that PHI. We also see the requirement of written privacy and security policies and procedures. I think this is one of the harder things for self-funded plans, because you're really going to have to work with a vendor or potentially a law firm to help you write these policies and procedures. But that's one of the things that we see a lot of self-funded plans struggle with, especially small ones who might be level funded, for example. Offering or providing the notice of privacy practices, that's a model notice that HHS provides, and often your TPA or ASO is going to also provide that to the employer, and then it's up to the employer to make sure that that's distributed out to participants. Some employers choose to put it in their open enrollment guide, but it really just depends. And then the obligation of entering into business associate agreements is something that the covered entity is going to have to do before they provide any PHI to any other service provider who is going to use that information to conduct their business. So for example, NFP as your broker, we all sign business associate agreements before we access your plan's PHI, because that's required under the HIPAA rules. I already talked a little bit about policies and procedures. This is specifically for security versus privacy, and security actually just speaks to kind of your PHI, but the electronic version of your PHI, and so rules are slightly different, but there's also the requirement for policies and procedures for those. And then obviously if there is a breach, then the plan has a requirement to notify affected individuals of this breach. And then depending on the nature of the breach, they might have the requirement as well to notify HHS. And so that's something that could come up. But really, when it comes to kind of self-funded plans and HIPAA, there's a lot more that needs to be done on a self-funded plan. And there is a little bit still that needs to be done on a fully insured plan, but on that self-funded, plan side, it definitely needs to be happening. And those employers should be aware of what their requirements are under HIPAA. And so moving on briefly, just to the ACA implications of being self-funded versus fully insured. I mentioned on the outset that we're not going to go into every single little possible change. And so there are a few other things kind of with the ACA, but we thought we'd bring up the biggest ones, okay? And so obviously, if you were going from fully insured to self-insured, one of the biggest changes you get under the ACA is the change to filing and paying the Patient-Centered Outcomes Research Institute fee, or the PCORI fee. This is something that the ACA imposed to basically support clinical research. And this is just a fee that is based on the number of covered lives that you have under the plan in a given year. And so there's a rate, which is currently $2.79 per covered live, that is reported on Form 720 for the second quarter. So that has to be done by July 31st. And interestingly, we thought this was going to stop because it was due to phase out, and then it got resurrected. And so now this will continue until at least 2029. But this is something that self-insured plans have to do, right? And it's all of them. And so even if you have, let's say, a fully insured medical plan, that self-insured HRA is going to be subject to the PCORI, so you should be doing that, okay? And so this is one of the bigger things that needs to be added to your compliance calendar if you are moving from fully insured to self-insured. One other slight change that we see has to do with reporting under Section 6055 and 6056. This is reporting that we generally kind of link up with the employer mandates. But remember that Section 6055 requires plans that cover people to let them know, hey, you received coverage. And this was important back when we had the individual mandate because people had to tell the IRS that they had coverage or they could face a penalty. Although the individual mandate is gone, there is still the requirement to provide employees or participants with a Form 1094B or Form 1095B to tell them that you provided them coverage, okay? And so with a fully insured plan, the insurer is going to do this. They just do that for them. Whereas with a self-insured plan, the employer is supposed to do it. And a small self-insured employer would use Forms 1094B and 1095B, but generally larger ones are ones that are going to be subject to the employer mandate because they have 50 plus full-time employees would use the Form 1094C and 1095C to report that they offered coverage to these people. One of the things we found this year is that there were a lot of self-funded, specifically level-funded, small employers who didn't realize that they were supposed to be meeting this requirement because they were technically self-funded. And so that's something we kind of saw very last minute. And then Section 6056 is the part that lines up specifically with the employer mandate and the requirement for applicable large employers to report to their full-time employees that they were provided minimum essential coverage that was affordable. Part of that form that's different for self-funded plans versus fully insured plans is, again, the idea that that employer can use Part 3 to report under the Section 6055 requirement and list out who all was covered under that plan. And so employers that are going from fully insured to self-insured will have to be kind of aware of the slight implications of that in their reporting. So that's it with the ACA implications. And Carol, I'm going to turn it over to you to talk about non-discrimination rules and then just some takeaways. And keep in mind, we need you to sit up close to your laptop.
Okay. Hopefully you can hear me clearly, and thank you for that overview of all those topics, COBRA, HIPAA, ACA. That was great. We're in the home stretch now. We want to discuss non-discrimination rules. And in particular, the Code Section 105 non-discrimination rules. So how do non-discrimination rules apply to self-insured plans? As we said earlier, self-insured plans have considerable flexibility to design the terms of the plan, the eligibility, benefits, contributions, and also to vary these terms by employer class. However, variances in benefits must comply with the applicable non-discrimination rules. And these protect not only against discrimination based on sex, gender, disability, claims history, etc., but also discrimination based on employee compensation and status. Most employers already offer benefits on a pre-tax basis through a Section 125 cafeteria plan, so they're familiar with the Section 125 non-discrimination rules, which prohibit variances in eligibility, benefits, and contributions that disproportionately favor key or highly compensated employees. Self-insured plans must also comply with the Section 105 non-discrimination rules, which are designed to prevent discrimination, prevent discrimination in favor of highly compensated employees. But the definition of a highly compensated employee and also the related tests vary from those under the Section 125 rules. Let's just review, how do the Section 125 non-discrimination rules apply? Now these apply to both self-insured and fully insured plans. If there's a cafeteria plan, and it applies to the cafeteria plan itself as well as the component benefits. Any differences in benefits must be based on bona fide business classifications. Examples would be based on geographic region, occupation, length of service. The variances, even with a bona fide class, cannot favor highly compensated or key employees. So under the Section 125 rules for 2022, a highly compensated employee is one who's an officer, a more than 5% owner in the current or preceding year, or who earned more than $130,000 in 2021, and for a new employee that would increase to $135,000 in 2022. A key employee is an officer with annual compensation in excess of $200,000, a more than 5% shareholder owner, or a more than 1% shareholder owner with compensation in excess of $150,000. The text tests focus upon eligibility, contributions, and benefits, and there's also a utilization component to some tests. And failure of the test results in taxable consequences for those highly compensated employees. So how did the Section 105 non-discrimination rules apply? Again, the Section 105 rules apply only to self-insured plans currently, which include any type of major medical plan, as well as health FSAs and HRAs. Again, differences in benefits must be based on a bona fide class, but the Section 105 rules prohibit variances specifically based on length of service or salary. And additionally, the 105 rules do not allow variances in waiting periods. Any variances cannot disproportionately favor highly compensated employees, which is defined a little differently under the Section 105 rules. For 2022, in HE, we wanted the five highest paid officers, or more than 10% owner, or among the highest paid of all 25% of employees. So the definition is broader than under the Section 125 rules, bringing in the highest paid of all 25% of employees. Someone could qualify as an HC under the Section 105 rules who didn't meet the compensation threshold under the Section 125 rules. The tests also focus on eligibility and benefits. There are some differences in exclusions between the Section 125 rules, and the failure of the test results in the taxation of the highly compensated employees on what's termed their excess reimbursements. What steps should a sponsor transitioning to a self-insured plan take to comply with the Section 105 rules? Well, first of all, review the plan provisions to ensure there are no variances in contribution to benefits based upon age, salary, or length of service. And also check to make sure there are no disparate waiting periods and entry dates. You want to remove these provisions from the plan upon notice to employees. In terms of the testing, contact the party responsible for your non-discrimination testing to verify that they'll conduct the Section 105 testing. Major testing is always advisable, so issues can be addressed before the end of the plan year. And understand that although testing is conducted by plan, the sponsor's entire control group is considered for certain purposes, such as the determination of HCEs. So it's important to do this testing. Passing the Section 125 test does not mean you're necessarily going to pass the Section 105 test. Finally, review the test results and take any necessary corrective action, which would depend upon the specific test failure. Generally, test failures will result in the taxation of excess reimbursements for your highly compensated employees. Final takeaways. The transition from a fully insured plan to a self-insured plan can result in additional plan design flexibility and potential financial advantages. However, it's important for plan sponsors to understand the financial risks and compliance obligations in making the switch. Initial steps include projecting the plan costs and determining the appropriate funding methods. The additional compliance requirements for self-insured plans arise under ERISA, the ACA, HIPAA, COBRA, and the Section 105 non-discrimination rules. The plan sponsors will likely engage service providers to fulfill certain obligations, but should understand their duty to monitor the providers. And the service contract should sufficiently address ongoing benefits compliance obligations.
Thank you, Carol. So we have about 5 minutes left. Patrick, I know that we don't have any outstanding Q&A, but any of the question and answer you think it would be worth especially mentioning kind of as we have a few minutes left before the end of the presentation?
Yes. Perhaps we could talk a little bit more about level funded plans and how they are considered self-insured. there was some confusion in the questions about whether or not they were required to fulfill certain obligations under reporting obligations specifically.
Thank you. Carol, you want to take that? You want me to mention it?
Yeah, generally, I mean, they follow the same requirements as the self-insured plans. And I think sometimes people are surprised to hear that. But they really are considered for benefits compliance purposes as the self-insured.
Yeah, I think that the government hasn't done us a ton of favors on this because we haven't gotten a lot of really on-point guidance as it pertains to level funded. But what we have gotten from them, even going back a couple decades, does make it clear that level funded plans are generally self-funded, right? So it's not like it's a gray area either, because what they have said is that usually that it is going to be considered a self-funded plan. And so, yeah, there's going to be a lot of requirements there. I think where employers kind of get confused is that they look at the insurer on a level funded plan, and because there's still, let's say, a premium set up and the funds are not paid out of their general assets, to them it feels just like if they had a fully insured plan. And frankly, that's how it's often marketed. But for pretty much all the benefits compliance intents and purposes, it is considered a self-funded plan. Okay. I see a question that we got about non-discrimination, talking about self-insured plans and how they cannot have a variance in waiting periods for different classes or divisions. Thank you for that, Chris. And I'll answer that live. Carol talked about this with non-discrimination. And this is one of the things that we noticed that a lot of folks are not aware of. The Section 105 rules are actually pretty clear that you should not be varying waiting periods for different groups. Now, the interesting thing about that is that if you do it, then technically the consequence would be that the highly comp people would kind of have tax consequences to that. So it wouldn't necessarily be all of the employees. And so it's interesting because that difference in waiting period may not even necessarily only benefit the highly comped, but that's who's going to get kind of quote unquote penalized or have the consequence for that. But that is something that is an element of Section 105 that we don't get on the on the fully insured side, if you will. Anything else, Patrick, that you want to speak to? I know we got a question about the ASO agreement and how much of that should be wrapped in with the plan document from an ERISA standpoint. And I will say that, the ASO kind of, it meets a few, it's kind of like the contract really between the TPA and the employer, and it kind of indicates what that TPA is going to do as far as administering the plan. But it also includes a lot of the language that lets us know what the covered benefits are for the plan, and those pieces, as well as how the plan is going to be operated from the standpoint of what participants or how participants are going to engage with the plan. It's going to include a lot of that information as well. And so although there might be some who might say, okay, well, we don't have to wrap the ASO agreement, I think there are portions of it that will potentially belong in an SPD to where it may just be better for you to make that available than risk not doing so and then having a complete SPD, or an incomplete SPD, if that makes sense. So with that final question, I think we're down to like seconds of the call. So Amber, I will turn it back over to you to do your outro. Thanks everybody for coming today.
Thank you, Beth and Carol, for sharing your valuable time and expertise with us today. To reiterate, today's presentation was recorded. We will be sharing the recordings in the follow-up email and on the NFP website. If there are any portions of this call that you missed, by Monday, you will receive an email with a link to the full recording. The PowerPoint slides used during this presentation will be shared in the same email. At the end of this call, a survey will populate in a new window. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you everyone for joining us, and have a great day.